Hello and welcome everyone. Today we'll be going through the non-invasive methods of measuring ICP in traumatic brain injury according to the Brussels conference. In this, they have given various guidelines as to when to use which non-invasive ICP monitoring and how. So what is this? nICP means estimating the intracranial pressure but by non-invasive bedside tools instead of our gold standard, that is the invasive catheters. It is useful in settings where these monitors are unavailable, they are risky, and there can also be contraindications to these catheters as well. So no non-invasive ICP monitoring is accurate enough to replace the invasive ICP. Let that be very clear, especially for getting the exact ICP numbers. There is no doubt about it that it cannot be replaced. All non-invasive ICP tools that we have are bedside, low cost and easy to use. The examples are optic nerve sheath diameter, transcranial Doppler and automated pupillometry. Each tool has its technical limitations and definitely requires some amount of training before you can actually utilize this. So the first one is automated pupillometry, which is measuring neurological pupillary reflex. If it is less than 3 with another abnormal tool, suspect raised ICP. If the NPI is more than 4, can help rule out raised ICP. Optic nerve sheath diameter, ultrasound and CT helps us, but what we are looking for is the ultrasound one. Optic nerve sheath diameter more than 6 mm suggests a raise in ICP, and any change in baseline more than 0.5 mm is also considered to be significant. Next is transcranial Doppler. It measures the blood flow in the brain arteries, mainly the middle cerebral artery. The pulsatility index, that is PI, more than 1.3 with diastolic flow velocity less than 20 indicates a very high possibility of raised ICP. So nICP with TCD estimates pressure more than 20 to 22 millimeters of mercury and suggests that the ICP is raised. So to summarize the recommendation of the Brussels conference, let's see how it is to be used in TBI patients. In severe traumatic brain injury, which is defined by a GCS of less than 9 with evidence of high ICP on CT, always use invasive ICP monitoring if available. Invasive monitoring is the gold standard and will always be the gold standard. If a patient is having severe injury, then prioritize placing this if possible. Prefer non-invasive wherever, that is, you will use the NPI from the automated pupillometry, the pulsatility index of the transcranial Doppler, or the nICP formula for the TCD, and optic nerve sheath diameter. These are bedside, non-invasive, and require some amount of training. Avoid other nICP methods like EEG, tympanic membrane displacement, retinal artery Doppler. These are mainly for research purposes only and not for daily clinical use. Always use at least 2 different nICP methods together, not just one. Increases the reliability and reduces the error. Integrate the non-invasive ICP findings with clinical assessment and imaging as soon as possible after admission. Do not rely solely on these measurements. Always try to combine two, along with it combine the imaging as well as the clinical assessment, and more importantly, do not rely on any number. Use the non-invasive ICP as a triage tool in patients with signs of high ICP by pupil, GCS and CT. It helps decide who is at risk and may need more aggressive monitoring and treatment. So when you're triaging, use this because it can be done very quickly. Use this and immediately start your raised ICP measures as soon as possible. Use this to help manage high ICP, not just for triage. Adjust treatment because the advantage of these things is that you can do it very serially. Repeat the measurements to look for change over time, that is measuring the ONST or the TCD over few hours. Pay attention to both the baseline as well as the change from the baseline. Any change is going to be of value. Only act on nICP values if you have good quality images and a reliable data. Poorly done scans can be misleading, so you must be confident about what you are actually measuring. Know the limitations of each tool. For example, ONST is not reliable in patients with eye injury or skull base fracture injuries. So must understand the limitations of each and every tool that you're using. None of the ICP is gold standard. So nICP is gold standard. So whenever you have choices available, use them. If nICP values differ between two sides of the brain, treat according to the worst value. For example, you can frequently find different ONSTs. So always treat the worst value rather than thinking that the patient is good. Use nICP in moderate TBI with positive CT to catch rising ICP early. Use non-invasive ICP even in severe cases with normal brain CT to monitor changes. Sometimes the CT looks normal, but the ICP may still be raised. Now, use ICP in moderate TBI with extracranial injuries when clinical assessment is difficult, because when you have severe trauma, making other assessment becomes very, very difficult. Next is, how do we manage patients using this non-invasive ICP tools? Always follow the established protocol. Use the Brain Trauma Foundation guidelines or the Seattle Consensus or the Crevis protocol when managing severe traumatic brain injury, especially if ICP is not available. In absence of invasive ICP, apply the Crevis criteria for suspecting high ICP. Use it to combine clinical CT and nICP to identify the raised ICPs. You do not have to try every lower step or treatment before moving to the next step. If clinical or radiological context suggests, you make a skip everything and go straight to aggressive management. If nICP and other data are not available, based on clinical judgment, also you can start aggressive management. Start with the basic, that is tier 0 treatment and nICP assessment. Begin with initial support measures and monitor the nICP. Use at least 2 nICP together, as we've already told. Only escalate or de-escalate therapy if both tools show similar trends. Decrease treatment intensity when both clinical and nICP findings together show improvement. If severe traumatic brain injury, monitor the nICP continuously if possible and at regular intervals. TCD can be used for continuous and repeated monitoring. In absence of invasive monitoring, repeat ONST and TCD every few hours. For severe traumatic brain injury, nICP assessment should be done at least every 2 to 4 hours, and for moderate, it should be done every 4 to 6 hours. So, what are the thresholds of non-invasive tools and for detecting and excluding intracranial hypertension? For automated pupillometry, you measure the NPI. If it is less than 3, then suspect high ICP. If it is more than 4, it rules out high ICP. Always combine both with another ICP measure before making a final commitment. Optic nerve sheath diameters more than 6, raised ICP, less than 6, unlikely of raised ICP. Transcranial Doppler pulsatility index more than 1.3, diastolic velocity less than 20, suspect ICP. These findings point to impaired brain flow, brain blood flow. nICP estimated by the TCD, if it is more than 20 to 22, suspect raised ICP. Important is also the trend in NPI drop more than 1, ICP changes to be suspected. ONST increase more than 0.5, ICP raised to be suspected. PI increases by 0.5, then possible shift in cerebral flow and ICP. Do not use changes in the TCD based nICP values alone to estimate ICP changes. This is very important. The calculation based TCD ICP measured, do not use it for calculations. Single value change is unreliable. So now we will look into various algorithms and how they help in managing the patients. The first is the algorithm which we are using for escalation of treatment in TBI, where we do not have a CT scan available. Next, what you need to do is observe the patient for any signs of intracranial hypertension. If you don't find any, then observe and re-evaluate it frequently. If yes, then go for tier 0 measures, that is basic supportive care, head up, optimize oxygenation, blood pressure management and sedation. Do a neurological assessment. If normal, then do your nICP assessment using 2 different devices, that is ONST and the TCD. If both are showing normal, then no need to escalate any therapy. Continue with your current care. If one or both is abnormal, then observe and re-evaluate. Mind you, you have to be cautious because one of them is still not abnormal. If abnormal neurological examination, then do nICP with two different methods. If both methods are normal, then please re-evaluate the patient. If both nICP is abnormal, then escalate therapy and re-evaluate your escalation. Remember this, that always repeat the nICP in similar physiological conditions, that is your BP, PCO2 should be equal. Don't change the position of the patient, the head position, everything must be equal when you are measuring, doing these measurements. Two nICP measurements for each assessment is important. For as we have already told, for severe traumatic brain injury, 2 hours, for moderate 4 to 6 hours. Next is the algorithm on escalation of treatment when CT is available. If that is the case, then first see if you want to you're suspecting any intracranial hypertension or not. If no, then just observe the patient. If yes, then go for tier 0 as we have already done, then go for a neurological examination. If it appears to be normal, then please do a CT scan. Now, after the CT scan, if the CT is normal, then do your nICP assessment. Then manage accordingly. If it is abnormal, then you can consider escalating your therapy. In the CT, if the neurological examination is abnormal, then obviously you have to go for CT, and if it is abnormal, you escalate your therapy. If it comes out to be normal, then you have to go for the nICP assessment. If it is normal, that is both things are coming up to be okay, then you're fine. But if it is abnormal in anyone, then you can again recheck and even consider escalation. Next is the algorithm for de-escalation of treatment when your CT is not available. So again, you observe the patient. If it is showing no problems, the patient is unstable, then obviously you continue with your management. If the patient is showing stability, then my plan will be to wean the patient. Then go for a neurological examination. If it comes out to be normal, then go for nICP assessment. If it is again normal, then you can wean. If it is abnormal, then go for the nICP assessment. If it comes out to be normal, then you need to observe the patient. If it comes abnormal, then you cannot wean and you have to re-evaluate. If the neurological is normal, but the nICP is abnormal, like this scenario, then you have to observe the patient a little bit. Finally, the algorithm is on the de-escalation when the CT is available. Similarly, if the patient is unstable, then you continue with your management. If you find stability, you will go for a neurological assessment. If it is abnormal, then you go for a CT. Either way, you go for a CT scan. If the CT scan in abnormal comes out to be abnormal, obviously there is no weaning. If the CT comes out to be normal, then you go for nICP assessment. If it is abnormal, then you have to cautiously observe. If both are coming normal, then you wean. In CT, normal neurological assessment and a normal CT, you obviously wean. If it is abnormal, again you have two choices: look for nICP, and finally you decide to wean and observe. So I hope the algorithms will be helpful. You can use it as your scenario is, whether you have a CT scan urgently available or not, and your patient's scenario, whether patient is improving or patient is deteriorating. I hope the presentation was helpful, and if you have these modalities available with you, you can start using the non-invasive ICP assessment using these algorithms. Thank you for your patience.